Nab-paclitaxel combined with S1 as adjuvant chemotherapy was
GC study showed that 5-year overall survival of patients with stage 3 gastric cancer undergoing D2 gastrectomy is still low. So this study addresses whether adjuvant nab-paclitaxel combined with chemotherapy is more effective than Celox in patients with stage 3 gastric cancer. And with normal RFT, LFT and CBC. This is the randomization. Patients with stage 3 gastric adenocarcinoma have underwent R0 resection. Randomized, total 313 patients were there. They are randomized to both the arms. This is the treatment regimen, the chemotherapy regimen. AS is an albumin-bound paclitaxel, which is given as 120 mg per meter square Q3 weekly on day 1 and day 8. And S1 is given from day 1 to day 14 every 3 weekly. And the Celox group, oxaliplatin 130 mg per meter square Q3 weekly on day 1 and capecitabine 1000 mg per meter square day 1 to day 14 given Q3 weekly. Endpoints are primary endpoint, which is 3-year disease-free survival rate, and secondary endpoints were overall survival and safety, and the stratification analysis was done on the basis of histological type, that's differentiation versus undifferentiated, pathological staging 3A versus 3B versus 3C. Now coming to the results, total 313 patients were there. In the albumin-bound paclitaxel group, it was 156 patients, and the Capox group, it was 157. With a median follow-up of 5.16 months. The 1-year disease-free survival rate was 87% in the AS group and 70% in the Capox group. And 1-year overall survival was 88% in AS group and 63% in Capox group. 3-year DFS and median DFS was not reached. Coming to the recurrence, total 12 recurrences in the AS group and 16 in Capox. And there were more peritoneal and locoregional recurrences in the Capox group. Coming to the adverse effects, neutropenia, anemia and thrombocytopenia were the most common adverse events. And in the AS group, the toxicity of any grade was 79% versus 72% in the Capox group. And the grade 3 and 4 toxicities were 39% in the AS group and Capox group, it was 22%. Now this is just a comparison showing the adjuvant chemotherapy regimens and the trials in gastric cancer. First coming to classic, it's a phase 3 randomized trial and recruited 1035 patients, included stage 2 to 3B patients, and the regimen was adjuvant Capox. The primary endpoint was 3-year disease-free survival rate, and it was 74%, with neutropenia being the most common side effect. Now coming to the next ASCTS DC trial, it's a phase 3 randomized trial with 1059 patients. It also included stage 2 to 3B. S1 was given as adjuvant regimen, and with a median follow-up of 2 years, the 3-year overall survival was the primary endpoint with a 3-year relapse-free survival rate of 72%. Now coming to the MAGIC and FLOAT, these were perioperative chemotherapy. It's a MAGIC is phase 3 randomized trial with 500 patients. It included stage 2 plus disease with ECF as the regimen given as perioperatively with a median follow-up of 4 years. Overall survival was the primary endpoint with a 5-year OS of 36% and neutropenia being the most common side effect. FLOAT is the trial which uses docetaxel Compared docetaxel versus this ECF, it was not a pure adjuvant study, it was perioperative chemotherapy with a median follow-up of 43 months. The 3-year overall survival was 57% with the addition of docetaxel, with neutropenia being the most common side effect. And this is this is the Chinese study which I have discussed today, which included 313 patients, compared AS, that is albumin-bound paclitaxel, and S1 versus capox. The 3-year DFS was not reached, but 1-year DFS was of 87%. And now coming to the conclusion, the evidence of the use of taxanes in the management of stomach and G-junction tumors are derived from various phase 2 studies, and most of the studies like CROSS, which are used taxanes in the neoadjuvant setting, V325 used in locally advanced G-junction tumors, FLOAT, which was taxanes were used in the perioperative chemotherapy. But in phase 3 studies in the with the use of taxanes in the adjuvant setting are limited. So this study uses albumin-bound paclitaxel with S1, provides a new potential adjuvant chemotherapy regimen for stage 3 cancer after D2 resection, and compared with the capox, AS regimen has better survival rates and acceptable toxicity profile.
Thank you, Gopika. So interesting point in this study is that it included taxanes, which is the active agent in many of the cancers in the first line. That is not in GE cancer. So they have included nab-paclitaxel with S1 in this adjuvant setting. And we have the evidence in the form of FLOAT or the CROSS trials where they have included the taxanes and which provided meaningful results in gastric cancer. So that is the one good thing about the study. Another thing is that we have compared with the standard arm, that is a classic trial arm, that is capox, and is still able to produce a better 1-year DFS and overall survival results. So pitfalls, it is a Chinese trial, and so far we only know the abstracts. So we'll wait for the entire literature to come out. Another thing is that they have used only the stage 3 gastric cancer, where the perioperative chemo is the standard right now with the evidence of FLOAT. So that is another thing. Another thing, always patients will tolerate chemo better in the preoperative setting than the postoperative settings. So there are issues with this studies. So we'll wait for the 3-year DFS or OS results to come out to get a better clarity. So in the era of biologicals and this immune checkpoint inhibitors, the changing the chemo backbone, which is interesting in this study.
The next topic is going to be presented by Dr. Vishnu Kumar. The session will be chaired by Dr. Google. The topic is upfront palliative resection of primary tumor versus no resection in patients with synchronous metastatic colorectal cancer.
Good morning all. Today I am going to present a abstract of a paper. It's a upfront palliative resection of primary tumor versus no resection in patients with synchronous metastatic colorectal cancer. It's a randomized phase 3 Cairo 4 study by Dutch colorectal cancer group. As background, around 20% of the patients in the colorectal cancers present with synchronous mets in the stage 4, and around in the retrospective data shows around 50% of all these patients undergo primary tumor resection either because of some symptoms like obstruction, pain or ileus, and in these patients that 30-day mortality rate is around 1.3 to 11.7%, and these patients includes both symptomatic and asymptomatic, and all these trials doesn't show whether that upfront resection was done for the intention of improving survival or not. So this study mainly Cairo 4 study, they intend to see whether the primary tumor resection in the synchronous metastatic colorectal cancers associated with any survival benefit. These are the previous trials in 2014 when this study was accrued. These are the studies which shows varying results. Few studies have shown the benefit of the primary resection and few doesn't. So this is the first prospective study planned to do see whether primary tumor resection is associated with any survival benefit. It's a phase 3 multi-center randomized control trial mainly to assess the potential benefit of the upfront primary tumor resection followed by chemotherapy versus chemotherapy alone was investigated. Eligibility criteria is all the tumors are histologically confirmed colorectal cancers. These patients have unresectable mets but resectable primary without any severe symptoms related to the primary tumor. And all these patients are not undergoing any neoadjuvant chemoradiation, all with a good PS score. And chemotherapy is based on fluoropyrimidine based chemo with bevacizumab. And the two arms, that is the upfront resection arm, this upfront resection, after randomization within 4 weeks they will go for resection, and once the patient is recovered, after 4 weeks they start the chemotherapy, and the chemotherapy will be continued until the progression of the disease or if there is any unacceptable toxicity. And in the systemic therapy alone group, after randomization within 4 weeks they start chemotherapy, and the chemotherapy is continued until disease progression or any unacceptable toxicity, and few patients have undergone the surgery because of the primary symptomatic tumors. So primary endpoint is the overall survival, and secondary endpoint are the progression-free survival, grade 3, grade 4 chemotherapy-related toxicity, 30-day and 90-day mortality, and quality of life, and number of the patients undergoing secondary surgery after of initially unresectable meds. It's a intention to treat analysis, initially intend to accrue around 306 patients, but only 206 patients were accrued. And randomization was stratified for number of metastatic sites, PS score, LDH, and also location of the primary tumor. So results, these patients were followed between August 2012, accrued between 2012 to February 2021. 206 patients were randomized to 103 patients each, and 2 patients were excluded in the primary resection arm. Total 204 patients were included, of which 57% are male, median age of 65 years, and 50% are right side colorectal cancers with good performance scores. Median follow-up of the study is around 63 months, and in the upfront primary tumor resection, 5% did not undergo primary tumor resection, and 13% did not receive subsequent therapy. In the arm without primary tumor resection, 1% did not receive the systemic therapy. So total number of cycles taken in the upfront resection arm is 9, and 11 in the upfront in the systemic therapy arm. So these are the results. The overall survival and progression-free survival was given in the abstract. We couldn't get the entire results. In the overall survival group, in the upfront resection arm, it is 22.2 months and 19.5 months with no significant p-value. And also progression-free survival is 10.1 months in each group. And in during the latter course of the disease, around 2% of the patients who doesn't underwent upfront resection underwent colostomy, and 16.5% requires some sort of tumor resection for symptom palliation. So in conclusion, in patients with synchronous metastatic colorectal cancer amenable to palliative systemic therapy without severe symptoms related to the primary tumor, upfront primary tumor resection did not result in any significant median overall survival difference compared to the immediate start with the systemic therapy. The same group I have studied interim analysis in 2021 in JAMA. They published. They see the 60-day mortality, and they also in that study also there is no difference in both group. But the patients with elevated serum LDH, AST, ALT, neutrophils, the PTR had a significant higher 60-day mortality compared to patients without having these characteristics. In this one, actually, they have seen the PTR, the primary tumor resection has more mortality compared to the upfront systemic arm. This is also one study, IPAC study by JCOG trial, published in 2021 in ASCO pubs, where they mentioned that primary tumor resection followed by chemotherapy showed no survival benefit over chemotherapy alone. Thank you.
Vishnu. Good morning all. The basis of this study is the prior retrospective studies like CARO and the CARO-2, where they are looked into the fact that doing a primary tumor resection followed by chemo, and they compared the proponents favoring surgery is of the idea that if you give upfront chemo and then when you take the patient for their complications like bleeding, perforation, and obstruction and what, the complications are manifold when a patient is given chemo upfront. So that is why the proponents of surgery favored primary tumor resection followed by chemotherapy in the adjuvant setting. So all these retrospective studies didn't show any benefit, and this is the first prospective study which looked into this aspect. And they initially looked, as per the study design, they were looking for at least a OS benefit of 6 months, according to the Dutch colorectal cancer group. But they couldn't find any. This is the initial data from the study, the CARO-4 study, but there is no survival or any progression-free survival benefit seen in this study. There have been similar studies like the IPAC study by the Japanese group, and there are German studies which all look into these facts, but all these studies couldn't elicit any survival benefit. So I think we should wait for further studies and further results from the Dutch group itself before embarking it into the guidelines and all.
Thank you.
Maybe the patient complex for systemic therapy.
I know that you are always abstract. So even there in Western countries also there will be a small percentage of patients who are not happy with chemotherapy, what it shows, or do not have trust in chemotherapy.
Biliary tract cancers is always associated with dismal prognosis. We have a study, a randomized study of consolidation chemo-RT versus observation after first-line chemo-RT in advanced GB cancer. To present the topic, I invite Dr. Megha from Radiation Oncology, and to chair the session, I invite Dr. Vishnu, Senior Consultant, Department of Radiation Oncology.
Good morning. Today I'll be presenting the study, the RAISE-GB study, which is a randomized study of consolidation chemoradiation versus observation after first-line chemotherapy in advanced gallbladder cancer. This is a homegrown study conducted at Sanjay Gandhi Postgraduate Institute of Sciences, Lucknow. The principal investigator was Dr. Sushma Agarwal from the Department of Radiation Oncology. The background of the study is that chemotherapy, that is gemcitabine plus cisplatin, is the standard of care for patients present with unresectable advanced gallbladder cancer. In spite of this, their prognosis remains poor. The UK Advanced Biliary Study trial established that gemcitabine plus cisplatin was associated with a superior overall survival, 11.7 versus 8.1 compared to gemcitabine alone in treatment-naive patients with advanced biliary tract cancers. And the value of concurrent chemoradiation after chemotherapy is uncertain. There has been retrospective data which shows that locally advanced cases have responded well to consolidation chemotherapy, and those with good performance status, resulting in improvement in overall survival. The trial aimed to assess the incremental gain in outcomes with consolidation CTRT versus observation and response in responders to first-line chemotherapy in advanced gallbladder cancer. This is the first randomized study to evaluate the role of consolidation chemoradiation. There were a total of 130 patients in the study. They were randomized in a 1:1 ratio with, to the observation arm and the consolidation concurrent chemoradiation arm. The inclusion criteria was patients in the age group of 20 to 70 years with locally advanced gallbladder cancer with a good performance status. Initially, they received chemotherapy with gemcitabine and cisplatin. The endpoints of the study were, the primary endpoint was overall survival, the secondary endpoints were progression-free survival, toxicity, and hepatobiliary symptom index. The locally advanced gallbladder cancer is defined as the mass that infiltrated the liver, the common hepatic duct, common bile duct, the portal vein, the common hepatic artery, or had enlarged lymph nodes in the portal region around the common hepatic artery, the celiac, the superior mesenteric artery, the aorta, or the interaortocaval or precaval region. Response assessment was done after 3 cycles of chemotherapy with CCT abdomen, and the responders, that is complete response, partial response, and stable disease, were planned for completion of chemotherapy. The exclusion criteria was those with multiple liver metastasis as evident on CT scan, presence of ascites, presence of obstructive jaundice, and poor performance status. Patients were excluded from the study. Coming to details in the experimental arm, radiation was delivered using a standardized 3D conformal radiotherapy technique on a linear accelerator operating at beam energy of more than 6 megavoltage. The total radiation dose was 45 gray in 25 fractions of 1.8 gray per fraction to the gallbladder, cancer, and lymphatics, followed by a boost of 9 gray to the primary. The radiation target is the primary along with liver infiltration and lymphatics, that is the periportal, the celiac, the superior mesenteric, and para-aortic lymph nodes till L2. The gallbladder mass along with the liver infiltration would be the gross tumor volume, and a 5 mm margin around would be the gallbladder clinical target volume. The nodal CTV would be delineated after combining the portal vein, the celiac artery, the superior mesenteric artery, and aortic nodes. A boolean of the gallbladder CTV and nodal CTV would be the final CTV, and a PTV margin of 1 cm would be given to the final CTV. The organs at risk are, the dose constraints would be mean liver dose less than 30 gray, mean kidney dose less than 18 gray, and other OARs were as follows: the stomach, the bowel, and their doses are to be noted. Concurrent capecitabine was given at a dose of 1250 mg per meter square. Weekly clinical hemogram and liver function assessments were done during the treatment. The demographic characteristics were well balanced in the study. 63% were women, 58% had T4 tumors, 42% had N2 disease, and 27% needed stenting for obstructive jaundice. Statistical consideration: the trial was designed to detect an improvement in 2-year overall survival from 8% in the control arm to 25% in study arm, with 80% power at 0.05 significance level. The resultant sample size was noted as 140 over a duration of 5 years with a 10% attrition rate. However, they recruited only 130 patients. Toxicities were documented during adjuvant therapy using the CTCA version 3. Toxicities arising more than 90 days since the completion of radiation therapy and attributed to radiation will be assessed according to the CTCA criteria and counted as late radiation toxicities. Quality of life forms were taken at baseline before randomization, the second week of RT, and 1 week after completion. Adverse events grade 3 or higher due to concurrent chemoradiation. The most common adverse event around the range of 13% was hepatotoxicity, followed by anemia, GI bleed, and nausea. The final results: this is only the abstract. The entire paper is not yet available. The median overall survival in the concurrent chemoradiation arm was 10 months versus 4 months in the observation arm, with a hazard ratio of 0.47, which is statistically significant. Thank you.
Gallbladder usually gets clubbed along with all the other biliary cancers in most of the trials, and there is very limited randomized data looking at chemoradiation in gallbladder, so anything we get helps. Here they have used 3D CRT, not BMAT or IMRT. That probably explains the higher toxicity reported. And I think one companion trial would be the paper published from the Tata Group a couple of years back that looked at resectability post chemoradiation, and they used a slightly higher dose, EQD2 of around 60 combined with concurrent gemcitabine, and they showed, I think, around 70% conversion to resectability, which has not probably been replicated in any other trial. So they use a slightly higher dose and concurrent gemcitabine. So I think they've not looked at the conversion to resectability in this case. We can probably wait for their feedback.
One is the survival in the control group is very low compared to previous historical studies. Gemcitabine historically gives 10 to 11 months.
was because the study started
I
recruiting in
agree.
2019.
But what about the first point? Why is the control arm so bad, doing so poorly? 4 months is worse than palliative care, worse than just not giving anything. Just show it the second last slide. Second last. No, second last slide. So are our patients that bad? 4 months survival.
So one more thing, some patients would have been a candidate for surgery.
Did not? Did
They have not operated any patient. None of them.
mentioned here?
It seems that none of it. Some would have been candidate for surgery.
So the TMH paper showed 70% of the patients were converted to the section after CTRT. So here there is suboptimal systemic therapy, suboptimal RT, as well as suboptimal survival.
But whenever we analyze some data, we have to be sure that the observational group is doing well. Because if the observational group does badly, then the trial will become a positive trial. The survival in the chemotherapy arm is only 10 months, which is equal to chemotherapy alone in most of the older trials. Chemotherapy alone is 11 months. 11 months. And chemo plus immuno is 13 months.
So this must have been a group where the baseline disease is so bad, or the performance is so bad.
Was not that bad.
Otherwise, we should have got that. Or Indian patients' TB cancer profile is different.
Can you show that patient characteristics like?
Or even the supportive treatments from India is less. Before or the case.
And the other issue is patient peritoneal disease. They have excluded metastasis, right? But they would have not identified peritoneal disease. Many of the patients.
Diagnostic lab may not have been a standard.
It's all CT criteria.
Yes, so they didn't do a staging laparoscopy to assess for peritoneal disease.
Have messed up.
That is fine. Stage 4 veterinary should have survived more than 4 months.
But it's finally good that they are coming from India.
Thank you.
Thank you. We are moving on to the next topic. So we had our trial study, that is Folfoxiri with bevacizumab in metastatic colorectal cancer. Irrespective of the RAS or BRAF status, we gave better results. So here we have an extension of trial study, that is ATASO trial study with Folfoxiri with bevacizumab and atezolizumab. To present the topic, I invite Dr. Sriram from Medical Oncology, and to chair the session, I invite Dr. Sudha Janagi, consultant Medical Oncology.
Good morning all. I'll be presenting about the ATISO tribe study, which is the addition of Folfoxiri plus bevacizumab and atezolizumab as upfront treatment in unresected metastatic colorectal cancers. The updated results. Around 95% of this metastatic colorectal cancers are either proficient MMR or microsatellite stable, and these cases are usually have a very less benefit from the first generation immune checkpoint inhibitors. Now coming to this phase 2 randomized ATISO trial study, it was conducted to verify whether adding atezolizumab to frontline Folfoxiri and bevacizumab could be beneficial in metastatic colorectal cancer patients, and it exploits the immunomodulatory effect of cytotoxic and anti-angiogenic agents. So if you see in this study, we have 3 agents. One is the Folfoxiri. The biology between adding this is immunogenic cell death. It promotes tumor-associated neoantigen release and also enhances the dendritic cell function. Talking about bevacizumab, it promotes tumor infiltration of CD8 lymphocytes, and atezolizumab, it promotes T cell priming and activation and anti-tumor activity. Along with T cell, it promotes the T cells by blocking PD1 and L1 pathway. Now coming to the study design, the eligibility criteria as such was previously untreated, unresected metastatic colorectal cancers, which was staged by RECIST criteria, and the age group was 18 to 75 years, and the ECOG performance status should have been less than 2, and ECOG equal to 0 if age is between 71 to 75 years. Adjuvant oxaliplatin containing chemotherapy was not allowed, and adjuvant fluoropyridine monotherapy was allowed if more than 6 months was elapsed between the end of adjuvant and first relapse. Now, adequate bone marrow and liver and renal functions, and there was no contraindication. There should have been no contraindications to immune checkpoint inhibitors. The study design basically was, in the control arm, they took FOLFOXIRI plus bevacizumab given up to 8 cycles, followed by 5-FU leucovorin and bevacizumab maintenance. And in the experimental arm, they took FOLFOXIRI plus bevacizumab plus atezolizumab, which was given up to 8 cycles, followed by maintenance of 5-FU leucovorin, bevacizumab and atezolizumab. And now, if there was disease progression, there was reintroduction of FOLFOXIRI, bevacizumab plus or minus atezolizumab for up to 8 cycles, followed by the same maintenance regimen. The primary endpoint of the study was basically progression-free survival, and assuming a median progression-free survival of up to 12 months in the control arm, 201 patients were taken into account, and there were around 129 PFS events reported. It should provide 85% of power to detect the difference between the PFS in the control and the exponential arm. Now, the study timeline was between November 2018 to February 2020. They started recruiting 218 patients, and once the recruitment was over, the follow-up was between February 2020 and August 2021. The PFS events reported was 159, and the median follow-up was around 20 months. The characters that were studied in this study were the gender, the median age, the ECOG status, presence of synchronous metastasis, whether prior adjuvant chemotherapy was given or not. There was a primary tumor site, whether it was right side or left side. The number of metastatic sites, if there was only liver metastatic disease, then how did they fare? The resected primary status, the RAS and BRAF status, and the right side versus left side, the RAS mutation and the MMR status. All these were almost comparative in both the experimental and the study arm, on the control arm. Now, coming to the primary analysis, the main findings were, in the intention to treat population, the progression-free survival was significantly longer in the experimental arm, with a median of 13.1 months versus 11.5 months. With no difference in response rate, 64% with 59%. There was no unexpected grade 3 or grade 4 severe adverse events. There was a significant interaction between the treatment arm and the MMR status, which were found. In the proficient MMR arm, the hazard ratio was 0.77, and the deficient arm, it was 0.10. Now, in the translational analysis of this study, there were several parameters that were studied, including the tumor mutation burden, immunoscore IC, PD-L1 TPS score, tumor infiltrating lymphocytes, the dermata-IO gene structure, gene signature. The main findings from this translational analysis was, there was a significant interaction between the treatment arm and the tumor mutation burden. It was as high as 6%. This immunoscore IC, even this was studied, this also showed a significant interaction between the treatment arm. It was as high as 32%. When the updated analysis was available in January 2023, the overall PFS events were 175, and the overall survival events were 118, and the median follow-up was around 37 months. In the updated intention to treat population also, there was like a significant PFS difference between the experimental arm and this control arm. Also the overall survival, though it was marginal, still it was statistically significant in the study arm compared to the control arm. Now, coming to subgroup analysis of both PFS and overall survival, in the MMR status, the p-value was 0.062, and in the tumor mutation burden, the arm that was around 0.009, and in the immunoscore arm, it was the p-value was 0.027. Now, coming to second line progression free survival, there was again compared to like similar to first line. Any second line therapy, it was around 79% in the control arm as opposed to 81% in the experimental arm. And second line therapy, when they used 5-FU, oxaliplatin, irinotecan with bevacizumab, in the control arm it was around 52% as opposed to 61% in the study arm where atezolizumab was included. Again, the updated PFS reports are also similar. And the outcomes according to the immunoscore arm and in the PMMR cohorts, these were also like similar to those of the tumor monocyte burden. Overall, summarizing this study, at a median follow-up of around 37 months, the addition of atezolizumab to FOLFOXIRI and bevacizumab as an initial therapy is confirmed to prolong PFS in molecularly unselected metastatic colorectal cancer patients. At a preliminary overall survival, around 54% of events, there was a trend towards longer overall survival that was observed. And adding atezolizumab to FOLFOXIRI and bevacizumab is related to better outcome in terms of both PFS. The hazard ratio was 0.7 and the p-value was 0.073. And also in overall survival, which had a hazard ratio of 0.83 and the p-value of 0.172. In the cohort of also in cohorts of patients with proficient MMR tumors. In the MMR cohort, the magnitude of PFS and overall survival benefit is heterogeneous according to whether it is the TMB status or the patients evaluated through immunoscore or any other the immunoscore high and low pattern. It was almost similar. The independent predictive impact of both immunoscore and tumor mutation burden is confirmed in the multivariate models in the MMR cohort by supporting the relevance of these markers that measure the tumor immunogenicity. Also now a phase 3 trial is going on by Gono Foundation to investigate the added value of addition of atezolizumab to upfront FOLFOXIRI and bevacizumab in patients with proficient MMR and immunoscore high tumors. Thank you.
So FOLFOXIRI plus bevacizumab is a regimen which has shown median overall survival of around 30 months in trial study. And this is the preferred regimen, first line regimen for unresectable metastatic colorectal cancer in a selected group of patients. And this selected group of patients include patients who are ECOG 0 preferably and right-sided or without RAS mutated metastatic colorectal cancer and synchronous metastatic colorectal cancer. So this regimen was used in trial 2 study also, and same has been the study design has been same here, except that atezolizumab was added in the experimental arm. Adjuvant oxaliplatin containing chemotherapy was not allowed in this study because 64% of the patients who were included in the trial study didn't take any benefit from the triplet chemotherapy plus bevacizumab arm. So such patients were excluded from further Gono studies. And the rationale for this combination has been described already. There were some biomarkers which were selected in this study. Some 6 biomarkers were selected, out of which in multivariate analysis TMB and immunoscore IC were found to show significant benefit with addition of atezolizumab to this regimen. And it was found that immunoscore IC was a promising biomarker, and there is a phase 3 trial which has been planned using immunoscore IC biomarker to study its role in this PMMR metastatic CRC patients.
Sorry?
to benefit from?
Filter out and they'll be started using. Otherwise, it must be a
In the intention to treat the group, there was a PFS benefit, sir. That was significant. After second line, there is no benefit. PFS 2, there is no benefit. There was a trend towards overall survival benefit in intention to treat. You have to wait for
PFS are 2 months, 13 months
PFS
versus 11 months.
benefit was significant, but OS there was a trend towards improved OS in ITT. It's not.
Thank you.
Thank you. We are moving on to the next topic. The pelvic radiation and 5FU-based chemoradiotherapy is the standard of care in rectal cancer. So, whether we can omit radiation in a low-risk rectal cancer, those who can undergo strictest sparing surgery. To address this, there is a prospect trial. To present the topic, I invite Dr. Chandrasekhar from Surgical Oncology, and to chair the session, I invite Dr. Deepak Kamodharan, Senior Consultant, Department of Surgical Oncology.
A very good morning to everyone. This is the prospect trial which compared neoadjuvant chemoradiation versus Folfox with selective chemoradiation in selective patients for locally advanced rectal cancer. The patients included, this was done only for intermediate and high risk patients, and low risk patients were excluded from the study, and patients who were having T4 disease or N2 disease were also excluded from the study. Background is approximately 8 lakh individuals were diagnosed with rectal cancer globally.
High risk was excluded.
Very high risk, sir. Please.
Very high risk was excluded.
Very high risk was excluded. And out of all the number of patients, half of the patients had locally advanced disease. So in a crectomy, it is standard curative intent treatment for locally advanced rectal cancer is pelvic radiation with concurrent chemotherapy, as it improves the disease-free survival by decreasing the local pelvic recurrence. But when we are giving RT for in neoadjuvant setting, the long-term side effects of radiations are like bowel and bladder dysfunction and sexual dysfunction will be there. So in order to avoid the side effect, long-term and acute short-term side effects of radiotherapy, this study was advised. So it compared Folfox plus selective chemo-RT in some patients versus chemo-RT as a neoadjuvant treatment prior to surgery for locally advanced rectal cancer. So, so this is the diagram depicting where we can divide the crectomy into based on the location, low, mid and high lesions, high rectal lesions. Low is less than 5 cm, 5 to 10 cm is mid rectum, and above 10 cm will be high rectal tumors. So if you classify the crectomy as low risk, intermediate risk and high risk, so low risk are the one who having CT192, that is limited to the colonic wall with N0. T3AB is involvement of mesorectum with less than 5 mm invasion and with no nodes on MRI, and the distance from MRF is more than 1 mm. These all patients come under low risk, which are directly taken up for the surgery without any neoadjuvant RT. So intermediate risk, high risk patients include CT3 CD, that is more than 5 mm extramural invasion, or N1, and the distance to MRF is more than 1 mm. So very high risk patients which were excluded from this study are CT4 group and N2 group. So study design was, it was conducted in multiple centers in across USA. It was unblinded trial and non-inferiority trial, randomized phase 3 trial. So here they took 1,122 patients, which were divided into two groups, interventional and control group. Interventional group, the inclusion criteria were like adults with rectal cancer staged as T2 and node positive or T3 node positive. T3 node positive were indicated for neoadjuvant chemotherapy. That is the patients with intermediate and high risk rectal cancer, and who are candidates for sphincter sparing surgery according to the primary operating surgeon. So these patients were divided into interventional and control group. Interventional group received 6 cycles of FOLFOX, each cycle at 2 weeks gap, every 2 weeks for 6 cycles. That is for 12 weeks. And some patients at the end of 12 months who after the completion of 6 cycles of chemo, they received MRI, and if the response is, they were looked for a response. If the response was more than 20%, they were taken for the surgery. If the response is less than 20%, they were given chemotherapy plus adjuvant. They were given chemotherapy. So out of 585 patients, 53 patients required chemotherapy after neoadjuvant chemotherapy. So other control arm was pelvic chemotherapy, that is 50.4 gray in 5.5 weeks, 5 weeks a day, and followed by surgery. These patients received concurrent oral or IV for 5FU or oral capecitabine, followed by surgery, followed by adjuvant therapy. So primary endpoint which was studied in this group is disease-free survival. Secondary endpoints were local recurrence, overall survival, complete surgical resection, complete pathological response, and toxicity and quality of life. Baseline characteristics of the study groups were comparable. Mean age of the study group population in both the groups was 57, and percentage of sex ratio was also comparable in both the groups, and most of the patients had tumor in the mid rectum, that is 8 cm from the anal bulge, and baseline MRI was done 84% in both the groups. So 16% of the patients received only interluminal endoscopic grading of the rectal cancer. So 16% of the patients did not undergo MRI staging in the pre-op setting. Clinical stage was mostly it was CT3 and with no nodes, or CT3 with nodes and node plus. So primary endpoint was disease-free survival. Like when you compared the study groups, that is FOLFOX versus chemotherapy. 5-year disease survival in FOLFOX plus or minus ERT was chemotherapy was 80.8% compared with the 78.6% in chemotherapy group, with a hazard ratio of 0.92. And these are secondary endpoints. Freedom from the local recurrence. So local recurrent free survival was also comparable between the both interventional and control group. That is FOLFOX group showed 98.2% versus chemotherapy group showed 98.4%, with a hazard ratio of 1.18. And overall survival also were comparable at 5-year follow-up, with patients intervention group showing 89.5% compared to 90.2 in control group. So when we compare the secondary endpoints in both the groups, complete rectal resection was achieved in 99% in patients who received neoadjuvant chemo only, compared to 97% in patients who received neoadjuvant chemotherapy. Like all the results are comparable. Low end resection 98% and 98%. Pathological complete responses 22 seen in 22% of the patients, 22 patients versus 24 patients in chemo RT group, and a positive radial margin was there in 1.2% patients in received FOLFOX intervention group compared to 1.5 in control group. This is the healthcare person reported toxicity. When we compare the toxicity between the neoadjuvant chemo versus chemo RT, the patients who received only neoadjuvant chemo, they had more diarrhea compared to chemo RT group, where it was the incidence of diarrhea was less, and but patients who received more neoadjuvant therapy, they had more chances of neuropathy compared to the chemo RT group. But when we compare the when we see at the toxicity during adjuvant treatment, the patients who received neoadjuvant treatment did well compared to the patients who received chemo RT. That is, patients during patients who received chemo RT in the neoadjuvant setting suffered more diarrhea and neuropathy in the adjuvant setting compared to the neoadjuvant group. These are the patient reported toxicity. So when we compare the both the groups, so if you like the side effects like anxiety, appetite loss, constipation, depression, diarrhea, dysphagia, dyspnea, edema, fatigue, mucositis, nausea, neuropathy, all were more in the patients who received neoadjuvant therapy in the pre-op setting compared to the patients who received only chemo RT in the that's control group. But adjuvant side toxicity were comparable, like it was same for both the patients. So if you compare the patients who received only neoadjuvant compared with the patients who received chemo RT, the side effect patient reported toxicity was more in patients who received only neoadjuvant chemotherapy compared to the patients who received chemo RT. The quality of life, it's trend toward improved quality of life with the FOLFOX and selected chemoradiation versus chemoradiation alone, but differences were not significant. And bowel function and sexual function favor FOLFOX and the selective chemoradiation group compared to the control group who received chemo RT in the neoadjuvant setting. So conclusions are, in this study, FOLFOX chemotherapy with selective use of pelvic chemoradiation is safe and it's not inferior for disease-free survival compared to pelvic chemoradiation alone for neoadjuvant treatment of locally advanced rectal cancer. And they achieved similar DFS of similar 5-year DFS, recurrence-free survival and overall survival. But there was some deficiency in the study that novel treatment approaches emerged for this population of patients during the trial, which included short course RT, which we are using in our hospital also, and shorter courses of adjuvant FOLFOX and total neoadjuvant therapy and non-operative management in a patients who showed complete response at the end of chemo RT, and immunoablative therapy for those with MSIH disease. So in this study group, MSIH status was not done for all the patients, and even MRI staging was not done for 16% of the patients. These are the main two limitations in this study.
Thank you, Chandrasekhar. You can go to that slide on results. Yeah, this one. This one. To summarize, basically I would like to take on to the negatives, the positives, and how we can incorporate this study in our setup. So the premises is we have very good local control, less than in 1 digit, 5%, around 5%, and very good survival, around 80 to 90% for stage 2 and stage 3 rectal cancer, where neoadjuvant treatment followed by surgery is the standard of care. Now, the last slides, there have been lots of, last 5-6 years, lots of combinations are available for giving the neoadjuvant. Now, this study is particularly from US, where neoadjuvant long course chemoradiation is the standard of care. So, if you see the subside, the mean diameter, I think the mean length was 8 centimeter. So it's fairly, the average tumor is 8 centimeter from the rectal. So it's upper bar, upper mid rectal. So they have excluded low rectal tumors. Now coming to the negatives, in Germany, there's an OCUM study, ACO, OCUM study, wherein they have, it's a prospective observational study. So they have done upfront surgery for the same criteria tumors, T2, T3 node positive. There's no T4 tumors, there are no high risk, that is the lateral nodes, the EMVR excluded. This is the intermediate, basically the intermediate risk tumors. In the OCUM study, they have done upfront surgery for the same criteria. And the other thing was the standard chemo rates. First in Germany. Germany again the standard is long course chemo radiation followed by surgery. There they found 40% of the tumors were overtreated with chemo radiation. And 25% of the tumors were actually stage 1. Because MRI inherently overstages tumor, bulky tumors. It can be T1 but it's over, so they get overtreated. So the premises is standard treatment gives a very good survival. Now we have to not overtreat this tumor. So the OCUM trial says that 40% of the patients you can avoid, in such group you can avoid any neoadjuvant treatment. So a major population in this study also could have avoided chemotherapy also. So that's a negative. Coming to the positives of the study, you see the pathological complete responsive rates are too high. 22 and 24. There is no randomized controlled study which states PCR with chemotherapy in rectal cancer. All the PCR rates we know are after some form of radiation. So this study says that you can have a pathological complete response rate after chemotherapy also in rectal cancer. But if you see 9% received, so only 10% of the people progressed on this neoadjuvant. Those received nothing. So they almost had the TNT protocol, that is 6 weeks of FOLFOX followed by LCRT followed by surgery. So it's almost the off-ratile induction chemotherapy protocol. So that must have contributed to the PCR rates. But the other arm, the long course chemoradiation arm, also at 24%. That's very high. Usually the PCR rates for after LCRT is in the range of 12 to 16%. This study, both arms have a big PCR rates. So the positives from this study is neoadjuvant chemotherapy in upper to mid rectal cancer can give you PCR if they are responding well. And you can avoid a stoma because you are giving, after neoadjuvant you are operating, again you are not giving RT, so stoma can be avoided. So these are the two positives. And what we do for this subset of tumor? What we do for this subset of tumor, we give short course RT and do early surgery. And when we analyze the data of 100 patients, we are also over-treating 25% of patients. That is, 25% could have had straight surgery. So, finally, how we can use this in our strategy, where we are following short course radiation. This significantly N2 disease, little intermediate risk upper rectal cancers, we can use this. We can give FOLFOX, reassess. If they are not responding, we can use short course RT and do early surgery. We do not go to the LCRT. So probably in upper, mid, bulky tumors, which are MRF safe, but nodes are N1 bar N2, we can give 6 cycles of FOLFOX, reassess, and then decide whether RT is required or go for straight surgery, wherein we can avoid a stroke. Any comments from the floor?
What is the final conclusion about the long course versus short course as a reward?
So it's fairly comparable. Fairly comparable, but because now things are moving towards a TNT to incorporate chemotherapy before surgery for the high risk. Again, everything is concentrating on the high risk. The low intermediate, we are debating, are we over treated? So to incorporate chemotherapy before surgery, short course gives an advantage as the treatment time is less.
Where do we use TNT and MVR avoiding of surgery? That is for the very high risk, very risk.
So the evidence has come from the very high risk because
What is our hospital for? Which patients do we use TNT and where we try to avoid or delay the surgery?
so to assess complete response in an upper rectum because of finger descent, it's difficult.
That is why we are not.
So we are using more. We are a little subjective, but we are trend towards TNTs towards the patient who require a permanent stoma, where It's a low rectal patient who require.
So that is not dependent on the T or N status. It's only based on the where the tumor site.
Yeah, it's where patients require a permanent stone, because here none of the patients, all patients are candidate for sphincter salvage. So the lower rectal tumors were excluded.
Have you ever compared
CCT profile is actually the same, sir. Vishnu?
Yeah, that is from we have not analyzed our patients. Our patients. So yes, we have to. We have a fairly good number who have done short
course early, 100 in each arm. 100 in each arm, short course early surgery, short course chemotherapy and surgery. Both arms are 100.
Then what do you think the prospect, what really worked for prospect? Is it the DME of the surgery or the chemotherapy?
Sir, I believe.
Because this says it's a non-inferior in terms of event wise.
So in terms when you're giving chemo radiation, pre-op chemo radiation versus pre-op chemo, this seems to be equivalent, but what I comment is maybe pre-op chemo is also an over treatment for select patients. Upfront surgery would itself have given this results. But definitely in that intermediate risk, pre-op chemo and there was no evidence that chemotherapy gives PCR. So this is new evidence that pre-op chemotherapy alone can give PCR and rectal cancer. So definitely.
Classical teaching is chemo will prevent the systemic recurrence. Drastic change after the introduction of DME. So DME is practically reduced the number of compared to the previous system. So we are talking about systemic therapy as far as the chemotherapy is concerned. Chemotherapy acts systemically and DME locally. That's how the whole concept is formed. But now you have to tell that chemotherapy works locally as well.
One point is chemotherapy, sir, this is upper rectal tumors. Foxtrot is there for colon. So upper rectal behaves like maybe rectum like colon. So that is the thing. It's might be the fault. There is evidence from Foxtrot that chemotherapy action. So this is basically upper rectal. Its behavior is more towards colon than lower rectal.
So that's the centimeter that is the catch.
Yes, catches. It's upper rectal. It's not actually. We are over treating with radiation. Probably that's a select subset where chemotherapy can be.
Atezolizumab combination given the longest survival in advanced HCC. So that is from the IM-BRAVE 150 trial. So we have a that is tried in the adjuvant setting after the ablative therapy. So to present the topic, I invite Dr. Munir from Department of Medical Oncology, and to chair the session, I invite Dr. Jeevan sir, head of the Department Medical Oncology.
Good morning all. I am presenting IM-BRAVE 050 trial regarding the efficacy, safety and patient reported outcomes as presented in the ASCO 2023. Actually this abstract was presented in the in early ASCR meeting. So this is the patient reported outcome. Regarding the background, currently there is no standard of care exists in the adjuvant setting for the treatment of patients with HCC following resection or ablation with curative intent. And it is shown that the post-operative recurrence is high, almost 63% recurrence at 5 years. And the rate is even higher in patients who are having high-risk features like large tumor size, multiple tumor, poor tumor differentiation, etc. So, and the recurrence is usually bimodal pattern. The most of the events occur within 2 years, and the second wave is usually at 4 to 5 years. So there is a very much unmet need of adjuvant treatment in these subset of patients. So this is a global open label phase 3 trial, randomized study of atezolizumab plus bevacizumab versus active surveillance in high risk disease of HCC. So it included confirmed first diagnosis HCC who had undergone curative resection or ablation, who are disease free with CP class A and high risk of recurrence, which is mentioned as multiple tumor, large tumor with poor differentiation, LVA, etc. And the with the ECOG performance status 0 to 1. After 4 to 12 weeks of treatment, they are randomized in 1:1 ratio to atezolizumab to 1200 mg every 3 weekly plus bevacizumab 15 mg per kg every 3 weekly. It was given for about 12 months, total of 17 cycle, and the other arm was active surveillance arm, and there is a provision of crossover when there is a recurrence or unacceptable toxicity. Primary endpoint of the study was recurrence-free survival assessed by independent review facility, and secondary endpoints include overall survival and investigator assessed recurrence-free survival. And there is a patient reported outcome endpoints which was used by the tool ERTC QLQ C30. Total of 5 domains were assessed, and it was further stratified based on the region and high risk features. Coming to the baseline characteristics, around 334 patients are included in each arm. The baseline characteristics are almost matched. Median age is 60 and 83% of the male sex, and Asian population. The study has happened in Japan, China and Taiwan. 82.6% are Asian, almost 77% are PS0, and 54% was PD-L1 status more than 1, and almost 73% the etiology of HCC was viral origin, and around 26% were non-viral or unknown. And the BCLC, regarding BCLC stage, BCLC stage A was included around 85% in atezolizumab beva compared to 83% in the surveillance arm. Regarding the resection status, around 87% of the patients underwent resection and 12% underwent ablation. In the resection arm, the longest diameter was 5, and around 90% have only one tumor. And regarding ablation, 70% have only one tumor with a median longest diameter is around 2.5 centimeter. Coming to the primary endpoint, which is the predefined based on the number of events after attaining around 234 events at 17.4 months, they have done a primary endpoint evaluation, and it found that there is a pretty much advantage in favor of the atezolizumab bevacizumab arm with a hazard ratio of 0.72 with a p-value of 0.012. And at 12 months, the recurrence-free survival was 78% in the atezolizumab beva arm versus 65% in the active surveillance arm. But one thing is, even though the curves were well separated, at 24 months we can see the curves are closing each other. And coming to the safety summary, the combination arm received a median duration of around 11 months. It is pretty much longer compared to other IMBRAVE 150 trial of unresectable or advanced metastatic HCC. The median duration of in that trial was the combination arm was received only, the median duration was only 5 months. And regarding the adverse events, the serious adverse events are occurring about 24% in combination arm, and the treatment related adverse events was 13%. And the grade 5 adverse events, that is death, occur in 6 patients, that is 1.8, and 2 patients had treatment related death. So, and around 46% of the patients in the combination arm, there is a dose interruption lead to adverse event leading to the dose interruption, and around 19% lead to the withdrawal from the treatment arm. Coming to the patient-related outcome, they used ERTC questionnaire. They included 5 domains: general health, 1 general health domain, and 4 functioning domain, including physical, role functioning, emotional functioning, and social functioning. And it showed that around almost more than 93% in the both arm completed all 3-week questionnaires. And if you're comparing the baseline score of ERTC, there is no much difference between the patient-reported outcome. And they are already predefined the clinically meaningful deterioration is means that more than 10-point decrease from the baseline, and almost all domain there is no much deterioration in the patient-reported outcome comparing the atezolizumab, bevacizumab compared to active surveillance. So this trial, the phase 3 trial, at the pre-specified interim analysis, the combination arm improved meaningful outcome in the recurrence-free survival with a hazard ratio of 0.72, and also the safety profile of this combination treatment is manageable. And the important thing is the reported outcome analysis showed that the trial with high baseline score in both arms for the health, physical, emotional, and social functioning, and did not experience any clinically meaningful deterioration at any point of time during the treatment period. So this may be a practice-changing option in the adjuvant treatment option for high-risk HCC, but obviously we need the overall survival data also. We are expecting the others are expecting the overall survival data by this year end or next year.
Thank you, Bhavya. In a way, this is interesting. First of all, we don't have any standard post-resection or post-ablation treatment. So this is one important landmark study. You can say like that. The important thing is that it happened in China. Most of the patients are in China, etc. You have very good screening and all those modalities and high incidence of SCC. Most of them are HBsAg positive, which they themselves are practically better than the other non-viral disease. Now, what is it? This patient-reported outcomes and health-related quality of that is probably important, because when you are giving an adjuvant treatment with so much of this thing, combination and all, probably it's all the data are excellent, because we don't have any problem with the patients are okay, happy. This translates that patients are happy with the treatment. I don't know. And after 2 years, there is a cursor crossing. So could be due to crossover, I don't know, because most of the progression happens after 2 years. Median duration of the atezolizumab was around 11 months. Combination given those. So in our part of the country, I don't know, because hardly we get resectable disease. Even if it is resectable, it would be because of the advanced nature of the child's score. We hardly get a chance to resect. Probably some ablation, but that's most of the time even ablation is also palliative ablation. So maybe we'll have to look into further details of this trial to translate to our practice. Difficult. Because historically they are prone to have 60%, even if it is 10 to 2 centimeter, it is prone to 60% will recur. They have selected the understand centimeter because the expected survival for them to assess the at least to show that impact. So this study is also immunotherapy. When it came to the for metastatic setup, and it's all pushing to the left and occupying to the adjacent position. So the only issue is whether this really matters in the real life. It's questionable. We don't know. disease is, I believe, very low, very low. Hardly like in a year, I don't know, we maybe, if I am correct, maybe less than 5 or 10 per year. Chance most of the year are not recognized. We are more enable and this non-viral.
The basic issue is the immunotherapy is not very effective in NASH. Not better, but at least the immunotherapy has got a differential like viral like the virus or but the other NASH and other process is not that. And that's a change in the last year.
And bridging therapy is always there.
Not the can be used as a bridge. Then so that similarly immunotherapy might come from that option.
Preoperative is that acetylmab plus bevacizumab before transplant. Before hepatic resection.
Very small evidence. Not that many.
Adjuvant therapy can even be used in patients who they are offering SBRT.
Yes, any sort of, even it's not resection alone, it's maybe ablation of any sort.
That's what SBRT, we have more number of patients on SBRT. So even those patients we can give it.
No, even our SBRT, if you see the data, it's not the pakka resectable equivalent SBRT. It's most of the time it's a palliative extent. It's not that either way. That's what my understanding.
Again, it's a recommendation for stage migration. Initially, you would have thought that this is a child E or the C, where you can't do a longer. But as and when required, it can change the stage. Right? It's called stage migration. So that is possible in that's approved in
Right. Thank you.
After 2 years, the curve will not.
That's right.
So then again,
Crossover.
actually this no meaning.
Crossover.
FDA.
Nicely cross.
The worrying thing is
So you are getting some DFR benefit, but no actual benefit.
Yeah, they are not mentioned anything about overall survival actually. Recurrence-free survival only. They are written. Thank you.
Thank you everyone. This is the last week of our ASCO update.